Good evening. My name is Barbara Boynes. I'm the Education Coordinator for SAPMIA. Tonight's education session, Gestational Diabetes, was funded by Country PHN. Before we begin, I'd like to acknowledge the Aboriginal and Torres Strait Island people who are the traditional owners of the country. We pay tribute to their physical and spiritual connection to land, water, community, enduring now as it has been throughout time. We pay respect to them, their cultures, elders past, present, and emerging. Some housekeeping points before I introduce our presenter tonight. If you require technical assistance with Zoom, please see the link to the FAQs in the chat feature. Your microphones will be on mute during the webinar. However, we encourage you to be involved by submitting your comments and questions through the quick Q&A function. The presenter will periodically stop to ask questions. There will be an evaluation form at the end of the webinar, and a certificate of attendance will be sent out electronically following tonight's presentation. I'm now going to, I'd like to introduce Dr. Jessica Gillard. Dr. Gillard is an endocrinologist, clinical pharmacological obstetrician physician. She undertook a specialist training in Darwin, Brisbane, and Adelaide. She has special interest in the management of women's health during pregnancy and the impact of chronic disease and medication on the unborn child. Dr. Gillard worked as a staff specialist clinical pharmacologist and physician at Flinders Medical Centre and is an endocrinologist and clinical pharmacologist at the Royal Adelaide Hospital. She also works in Brighton, Ashford and Mount Barker, offering endocrine, medicine and clinical pharmacological private consulting services. In addition to her clinical work, she is a lecturer as an academic coordinator at Flinders School of Medicine. I'd like to hand over to Dr. Jessica Gillard. Thank you.
All right, thank you everybody for giving up your Thursday evening to come and be part of this workshop / presentation on the management of gestational diabetes in pregnancy. I'd initially targeted this presentation more towards diabetes educators, but there's very much applicable to GPs and allied health staff as well. Please feel free to ask questions as we go, and each section break I'll have a look at the Q&A section, and if anyone's asked any questions I'll try and address them for you. So let's see if I can share my screen. All right, is that working this time? I don't think so. We'll try again. It's been a bit hit and miss with getting it to work tonight. Barbara, can you see my screen?
Not yet, Dr. Gillard.
All right, can you see it now?
Not yet, just your
Okay.
desktop.
So we got it to work before everyone came on. I'll make sure I've got that up and try it one more time. Sorry everybody, we did have this working before we signed in. Can you see my presentation?
There you go.
Okay. Fantastic. Sorry about that, everyone. So as Barbara kindly introduced me, my name is Dr. Jessica Gillard. I'm working at different places across town, both private and public, and also have an academic interest and linked with the University of Flinders University. So particularly as a clinical pharmacologist, I ensure that I never have any disclaimers to acknowledge. And if you need any assistance, this is how you can get a hold of me, and I'll do my very best to assist you and your patients where I can. So tonight we're talking about gestational diabetes. So as you're all aware, there's multiple different types of diabetes. Type 1 is the most complicated to manage in pregnancy, along with type C, the pancreatogenic diabetes. But type 2 diabetes is becoming much more of a problem in our population. Hence, we're having more women who are pregnant with type 2. It's very similar to the management of gestational diabetes. However, the difference is you need to think about preeclampsia and also a need for folate in these women. All right, so tonight's presentation, I'm wanting to have a bit of an understanding of the pathophysiology of gestational diabetes, how to diagnose it, the treatment targets, how to manage it, complications as a result of gestational diabetes for the mother and the fetus, and then some examples. Towards the end of the presentation, I do urge you to ask any questions if you're having trouble with any of your patients. All right. So during pregnancy, there's metabolic adaptations in insulin sensitivity. During early gestation, insulin sensitivity increases, and this promotes the uptake of glucose into adipose stores in preparation for the energy demands of later pregnancy. As the pregnancy progresses, a surge of local and placental hormones, mainly estrogen, progesterone, leptin, cortisol, placental lactogens, placental hormones, promote a state of insulin resistance. This mild state of insulin resistance also promotes endogenous glucose production and a breakdown of fat stores, resulting in a further increase in blood glucose and free fatty acid concentrations. As a result, blood glucose is slightly elevated, and this glucose is readily transported across the placenta to fuel the growing fetus. So to compensate for the increased insulin resistance, there's beta cell hypertrophy and hyperplasia, and an increase in glucose-stimulated insulin secretion. So it must be remembered that the baby's main fuel source is glucose. So when talking to women about restricting carbohydrates, we really advise against a ketogenic diet because the baby's at risk of starving. So the whole point in the insulin resistance in pregnancy is to provide fuel to the fetus. So in normal pregnancy, you get that beta cell hypertrophy and hyperplasia, which enables you to have an increase glucose stimulated insulin secretion. But in gestational diabetes, the mother's likely to have a degree of pre-existing insulin resistance and impaired glucose tolerance, and she's unable to meet these demands. So a GDM pancreas is unable to produce enough insulin, which then results in hyperglycemia. And the rate now is about 12 to 14% of pregnant women developing gestational diabetes. So how we diagnose diabetes has really changed over the years. Back in 1964, O'Sullivan was the first person really to describe this concept of gestational diabetes, and they described it as simply being glucose intolerance with onset of first recognition during pregnancy. Now, that's very broad and not so much the case now, as we often do pick up type 2 diabetes during pregnancy. That's the first time it's recognised, and type 2 and gestational diabetes are two different beasts. So it should be noted that all criteria used for the diagnosis of GDM were chosen to identify women at high risk of developing diabetes after pregnancy, or derived from criteria used for non-pregnant individuals. They were not developed to identify pregnancies with increased risk of adverse perinatal outcomes. So work's subsequently been done looking at adverse perinatal outcomes, and that's refined RBGL targets during pregnancy. So this is us down the bottom from about 2016 is when we started using these criteria. All right. So, 2014, there we go. So back between 91 and 2014, ADIPS, the Australian Diabetes in Pregnancy Society, had a guideline recommending that people do a non-fasting glucose challenge. So where they would drink 50 grams of glucose in an unfasted state. And if they had a 1 hour plasma glucose of greater than 7.8, then they went on to do an oral glucose tolerance test of the 75 grams that we get women to do now, but there were different cutoffs. Now, I have seen that some older obstetricians are still using these older criteria, but we're very much promoting just going straight to the oral glucose tolerance test. The problem with the glucose challenge is that if women have a elevated level, then they have to go and do a glucose tolerance test. So you might as well just get them to do one. And the glucose challenge doesn't take in account what a fasting blood glucose level is. And it's not that unusual to find a woman with an elevated fasting blood glucose but doesn't have issues with postprandial hyperglycemia. So I think it's very important that we do use the new guidelines, which is recommended by ADIPS from 2014 onwards, of getting all women between 24 and 28 weeks of gestation to do an oral glucose tolerance test with a 75 gram glucose load. They need to be fasted, and then we get a 1 hour and a 2 hour plasma glucose sample. Now, you may be aware that there's been some discussion about different ways to diagnose GDM in this COVID era, and I'll touch on that later in the presentation. So we need to remember that this may be the time that we diagnose type 2 diabetes for the first time, and we use the same criteria that we would use for a non-pregnant woman to diagnose type 2 diabetes. So if their fasting's greater than 7 or their 2 hours greater than 11.1, then we don't just call them GDM. We will give them that label of type 2 diabetes. So between 2000 and 2017, the rates of women being diagnosed with gestational diabetes in Australia tripled from 5 to 15%. So this then meant that ADIPS didn't really want to adopt the new AIDPSG guidelines, which are what are current guidelines, as they predicted an impact that it would have on resources. I remember this being quite a significant discussion held in the units that I was working in, just simply for workload. Do we have enough diabetes educators? Do we have enough endocrinologists? How would the GPs cope with this influx of new diagnoses? But it really had to be weighed up with the evidence suggesting the need for lower targets and lower cutoffs for diagnosis. So there are times that we need to do early screening, and these are women who are at higher risk of having gestational diabetes. So this is all outlined in the ADIPS guideline and in many of the GP guidelines as well. We recommend that women with 1 high risk factor or 2 moderate risk factors actually undergo an oral glucose tolerance at 16, 18 weeks. If they're negative at their first oral glucose tolerance test, that doesn't mean that they don't have to do a later one. They still then fall into the 24 to 28 week category with all other women. So the high risk factors are previous gestational diabetes, whether or not they've previously had an elevated BGL. We find women who are older, so greater than 40, are at much higher risk. And if someone has a family history of diabetes or a sister with gestational diabetes, women who are obese or have previously had a large baby, so one weighing greater than 4.5 kilos or greater than the 90th centile. Women who already have a degree of insulin resistance from a background history of polycystic ovary syndrome, or women who are on medications that are going to put them at higher risk of having hyperglycemia, so the corticosteroids and antipsychotics. If women are from essentially a non-Caucasian ethnicity, then that's considered a moderate risk for gestational diabetes. In particular, in Indian subcontinent women, we find a lot of gestational diabetes, and women who are overweight, not necessarily obese, are also at a slightly higher risk as well. So, as mentioned, there has been some discussion about the diagnosis during COVID-19, and there's been a lot of debate around this, and this guideline ended up just being put out, so there was something that went out. It was not really a consensus guideline. In South Australia, I think that we should now be considering ourselves as essentially post-COVID as far as using these diagnostic criteria. However, if you've got a woman who really does not want to undergo an oral glucose tolerance test, then you could be using these. But I really need to emphasize that these criteria were to facilitate social distancing, not best practice. So I really urge everyone to go back to the original guidelines of using an oral glucose tolerance test unless the woman's refusing to. So you can do an HbA1c in the first trimester, and an HbA1c of greater than 5.9% has a specificity of 98% and a positive predictive value of 52%. So we will be picking up some women who don't have gestational diabetes, but we will be picking up most women with gestational diabetes. Now, if they're a general non-high risk woman, you can get them to do a fasting blood glucose level, and if it's less than 4.6, then it's clear that they don't have gestational diabetes and they need to have an oral glucose tolerance test. I do want to emphasize here that we would be missing women who get a postprandial hyperglycemia, which is why these are not going to replace our current guidelines, but it's a substitute. Now, if women have a BGL of greater than 1.5, then they do have GDM based on their fasting blood glucose level, and they don't need to do an oral glucose tolerance test. If their fasting's between 4.7 and 5, then they're really in that no man's land where we do recommend that they have an OGTT. So I haven't used these guidelines at all because I haven't felt that we've needed to in South Australia, and all the women that I've seen have felt that it was appropriate to do an oral glucose tolerance test. But as I said, if you have someone who's refusing to do one, you can use these for the time being. But this is something that I definitely don't recommend that we're using ongoing. All right, so I had mentioned using an HbA1c in the first trimester, and the HbA1c does reduce during pregnancy. So this is a study back in 2004 that looked at the HbA1c in non-pregnant and pregnant women without diabetes. And you can see that a non-pregnant HbA1c of 5.5 became a 5.1 in early pregnancy and a 5 in late pregnancy. It's really only reliable for the diagnosis of type 2 diabetes, where they have an HbA1c greater than 6.5%. And that's because as it goes down during the pregnancy, if you find a woman who has an HbA1c of above 6.5, then it would be even higher in a non-pregnant state. We don't have any studies that are able to give us cutoffs for second and third trimester. And I wouldn't be recommending that you're doing an HbA1c on a woman with GDM or type 2 diabetes. So I'm just going to see whether or not we've got any questions on, sorry. Do we have any questions, Barbara? I can't see anything.
No questions at this stage.
Beautiful. Okay. Feel free to ask as we go. So wanting to have a look at the treatment targets now. So back in 2000, an Australian study, mainly run out of Adelaide and the Lyell McEwen, investigated the impact of treating GDM versus standard care, and this was the A-Choice study. So 490 women were given an intervention of treating GDM, and 510 women were just left to standard care. The intervention was dietary advice, where they kept their fasting blood glucose level less than 5.5 and their 2-hour blood glucose less than 7, and they were given insulin if they needed to maintain those levels. What we saw was that there was a reduction in serious perinatal complications, death and shoulder dystocia, but there was an increase in induction of labour and admission to the neonatal intensive care unit. So the targets that they use here weren't as strict as we have now, but it was the first point of seeing that gestational diabetes was actually really needing to be treated. So 3 years later, we had the HARPO study, which was also conducted in Australia with quite a few members of the teams that I work with in Adelaide and in Brisbane. And this study was to clarify the association of the levels of the maternal glucose, which was lowered, was to investigate an association between maternal blood glucose level and perinatal outcomes. And this is really the study that led to the treatment targets that we have now. So everyone always refers to the HARPO study, so that's the one for treatment targets. So this was a really big study. It was a cohort study of 25,000 women across 9 countries and 15 centres. Women were diagnosed with GDM following a glucose tolerance test between 24 and 32 weeks. And what they were looking for is, were there big babies? How was the baby delivered? Was there fetal hypoglycemia? And how much insulin was the fetus producing? There was also secondary outcomes, but as with any study, it's never powered for its secondary outcomes. So having a look at the results of the HARPO, it showed that with increasing maternal glucose levels, the frequency of each primary outcome increased. But as you can see for neonatal hypoglycemia, it wasn't as significant as the weight above the 90th centile, need for delivery via C-section, and the amount of fetal insulin production. So following the HARPO, this is where we've got our targets now of having a fasting of less than 5, a 1 hour of less than 7.4, and a 2 hour less than 6.7. And these targets were picked based on a 1.7-fold increase in fetal macrosomia. So the fetal size based on this graph here. So the problem with the HARPO study is that there was really an absence of clear cutoff values for normal and abnormal test results. And this implies that the thresholds that we've selected by definition are arbitrary, and it really is a spectrum. Now, you can see that there's a 1 hour cutoff. We do recommend using a 2 hour cutoff, because what we're hoping and expecting to see is that the maternal glucose has returned back to normal within 2 hours. However, for some women, it's just too difficult to get them to remember to check their blood glucose level at 2 hours. And that's when I get them to use the 1 hour cutoff. It's really important to make sure that they know that the 1 hour is for 1 hour and they're not aiming for a 7.4 at their 2 hours. All right. So I will just stop for a brief moment because I saw there was a question. Let me know. Okay. Are there any links between vitamin D deficiency and gestational diabetes? Not clear-cut associations that I can demonstrate with evidence. There's some thoughts that vitamin D may be involved, but nothing of really great significance. The concern with vitamin D deficiency in pregnancy is more to do with maternal, calcium intake, and then the fetal bones being able to deliver. Also, mothers who have a very low calcium intake are at risk of preeclampsia, also meaning that we need to make sure that everyone's vitamin D replete during pregnancy. All right, so thanks for the question. I'll go on now. So when to refer to you guys? So I think it's really important that all patients with GDM are referred to a diabetes educator. Now, I don't know if we've got any dietitians with us today, but I also recommend a referral to a dietitian. If a patient's unable to speak fluent English, I think it's really important that we get a face-to-face interpreter. But I've spent time working out rural and remote, and I know that we don't always have the luxury for that. So a phone interpreter is next best. I really try and avoid using their husband because you know that in some situations, sometimes cultural and sometimes just dynamic in the family, that not everything is passed on appropriately, and he will answer what he thinks the right answer is, not necessarily what she's feeling or believing. And there's a lot of really good online resources in different languages. So a diabetes educator is able to provide some advice on management via diet. I think it's great if we can get the dietitians involved because of course that's their specialty. But if not, diabetes educators are also really key to passing on this information to our patients. So down the bottom of the screen is a link, but all you need to know is go to the Women's and Children's website. So just via Google, Women's and Children's Gestational Diabetes, and it gives you a really good guide on advice to managing gestational diabetes and the type of diet that should be consumed. Now, I mentioned earlier about glucose being the primary fuel source for the fetus. And so women really do need to consume carbohydrates. I don't go into giving them too much educational advice regarding portions versus serves versus individual grams, like you would when you're teaching someone to carb count if they've got type 1 diabetes. But I tend to let them know that we're thinking in about 15 gram serves, and they should be having about 2 to 3 serves or 30 to 45 grams of carbohydrates with their main meals, and then having 1 or 2 snacks throughout the day of 15 to 30 grams. I really recommend that if they're when they're having carbohydrates with their snacks, that they're low GI, and if they're able to, keeping their meals low GI as well. So in a dietitian or diabetes education session, teaching them how to read and count carbs in a recipe may be possible, and I like women to be able to have an idea, but that is sometimes too complicated for some women, and giving them a bit more of a guide is better. Now, you've all got the skills of being able to carbohydrate count, and some women have very set meals, and you might be able to provide them with what a 2 to 3 carb meal would look like. Now, I see a lot of women from the Indian subcontinent, and they always have high blood glucose levels, which are meal dependent. So I make the rule, it's either rice or dal or a chapati. It's not all three. And then they tend to do a really good job of keeping their blood glucose levels within target. Whenever you see a high spike, it tends to be when the dal and the chapati have been had together, or the dal and the rice, etc. So that's just a piece of advice if you're seeing lots of those women. I think it's also important to give women free foods, so to speak. So these are things like your salads, your vegetables, not of course your high starchy ones like potatoes and corn, and some fruits, particularly the berries. They can add lemon and lime as flavouring to things. I do warn them about the dilemmas with bananas. All people in general tend to get a blood glucose spike following eating a banana, particularly ripe bananas. But I do notice in the gestational diabetes population, they are particularly sensitive to bananas. But then again, everyone's an individual and it's not going to occur across the board. But go easy on the bananas is what I always say. A lot of women ask about artificial sweetness, and I do recommend using a sugar alternative, and they are safe for pregnancy, except for cyclamate and saccharin, so the 952 and the 954. And yeah, so just I tell women that you can have your Equal or your Splenda, which are the most common brands in Australia. Now, having some sugar is not the end of the world, but really try and keep it to half a teaspoon with a main meal. A lot of women that we see have got children already, and there's birthdays, birthday cakes and things like that, and they don't want to be missing out on that with their children. If they can, keep it to a minimum and try and have it as really a treat rather than an all the time. And so this is part of what's come out of that women's and children's document that I've been talking about. I find it just can really help women to take it home and read and see if they can work it out themselves. All right. So whilst we like to think and hope that most women can manage with diet alone, it's often not the case. So insulin really is first line. Insulin doesn't cross the placenta. It's a large protein molecule which is unable to cross. I prefer to use Protophane or Isophane for elevated fasting blood glucose levels, and I tell women to take it at bedtime. They can theoretically use Lantus. There had been some debate years ago about whether or not Lantus was safe in pregnancy because it binds to has the ability to bind to an IGF receptor, and so then there was concerns that maybe the baby wouldn't grow properly. That's all been debunked now, and we use glargine in women with type 1 diabetes all the time. But women with fasting hypoglycemia really do best with the Protophane because it's out of their system come breakfast time. Now, if you're looking at where to start, about 4 to 8 units. I will sometimes make larger jumps depending on the woman, but that tends to be a really safe area to start. And ask your GP or endocrinologist where they're wanting you to start. I have no allegiance to Novo Nordisk, so it doesn't necessarily have to be Novo Rapid. Humalog would be just as good, but Novo Rapid is used more in the public hospital system, hence why I prescribe it more. So I use that for the fasting postprandials. I try and get women to take it the the 15-20 minutes before their meal, but that's often very difficult. So getting them to take it at least at the beginning of the meal and starting somewhere between 2 to 6 units pre-meals. If you ever have difficulty titrating as a diabetes educator or as a GP, I do recommend a referral to an endocrinologist, simply just because we do this day in, day out, and I'm much more comfortable making large jumps simply through experience. And sometimes these women, we need to get them to target, particularly when they're diagnosed late and with really high levels, than what we've got time to by doing it slow and steady. All right. Now, metformin, I think, and I'm assuming most of you are fairly all comfortable with these days. Metformin is used second line, but it does often get used for women who refuse to use insulin or have mildly elevated levels. So we've been using metformin in pregnancy for over 40 years now. It was initially used more in the first trimester, and that's where our first lot of data came from women who had polycystic ovary syndromes who were still on metformin when they got pregnant. But we've been using it now for the treatment of gestational diabetes. Occasionally, I will still find women whose pharmacist won't prescribe it for them because they're pregnant. But I will warn women that well, this was more when I was working in the territory, that their pharmacist may question it, but I very much am happy for them to have it. So we do need to educate women about the fact that metformin does freely cross the placenta, and some women can't cope with the idea of crossing the placenta. However, lots of things cross the placenta, and that isn't necessarily a bad thing. Here's a study that was only published last year that compared metformin to insulin, and it showed that metformin resulted in lower birth weights. There was more macrosomia in babies treated with insulin rather than metformin, and there was more babies with large for gestational age with insulin rather than metformin, which is led to another study that we're doing. So I think it's important to know that metformin has a place and also doesn't have a place. So if you have a baby that's got intrauterine growth restriction or small for gestational age, I say no to metformin, because it's very clear that it's associated with lower birth weights, and we want those babies to be able to grow as much as they can. However, in a baby that has got a large AC, so on the reports when they get their ultrasounds, AC, their abdominal circumference, does often go up in babies of mothers with gestational diabetes. I think metformin definitely has a place. So the MIG trial, yet another Adelaide trial, we've got very good researchers, particularly William Hague at the Women's and Children's Hospital, who've been leading a lot of this metformin research. So the MIG trial was published back in 2008, and it compared outcomes of babies born to mothers with GDM treated with either insulin or metformin. There were 750 women included, and so in women with gestational diabetes, where metformin alone or with supplemental insulin, let me just go through. Yeah, sorry, I'm just trying to look at my slides. So what this trial showed was that in women with gestational diabetes, metformin alone or with supplemental insulin is not associated with an increase perinatal complication as compared with insulin, and they were using a primary opposite outcome of neonatal hypoglycemia, respiratory distress, phototherapy, birth trauma, their APGARs at 5 minutes, and prematurity. And they also found in this study that women preferred to use metformin over insulin. So just looking at the results in more detail, they did show that babies that were mothers that were treated with insulin, they did have a higher rate of hypoglycemia, which is understandable because metformin in itself doesn't cause hypoglycemia, whereas insulin can. And they did find a statistically significant, but not a clinically significant, increased rate of babies being born before 37 weeks of gestation in the metformin group. So these, the babies in the average gestational age, or the mean gestational age for babies in the metformin group was 38.3 weeks, but in the insulin group it was 38.5 weeks. So about half a day. So I don't take that as being clinically significant despite being statistically significant. Now, I had mentioned that we're doing a study at the moment. It's called the Mighty Trial, and patients are still being recruited for this. It's a randomized controlled trial with 500 participants, and what we are hypothesizing is that metformin and insulin in pregnant women with, here in type 2, but we can carry it over to GDM. They'll have lower insulin requirements, they'll have improved glycemic control, decreased weight gain, and improved baby outcomes. So our thought is even in women who are needing insulin, giving them some metformin may have positive outcomes for their babies. So this is a handout I used to give all women who I was starting on metformin when I worked in Queensland, but I still give it to them down here. I just printed out from the Queensland Health website. It's an information sheet all about metformin. So I think it's really important that we make sure that patients have the appropriate information to make their own decision on whether or not they want to use it or not. So let me just go back. So this was my section on metformin. I saw there was a couple of questions. Let me try and bring them up. So is there a risk of hypo for baby if mum's taking metformin? No. I'll answer it in two ways because I'm not sure exactly what your question is. Is there a risk that the baby's going to hypo in utero from taking metformin? No. Is the baby going to have metformin on board postpartum and hypo? No. Is the baby still at risk of having hypoglycemia from uncontrolled diabetes where the mother is hypoglycemic? Yes. So babies who have hypoglycemia following their mothers having hyperglycemia, it's because the babies are used to being in a hyperglycemic environment. Therefore, the baby is having pancreatic hyperplasia and hypertrophy. It's pushing out more insulin itself. So then when it's born, it's no longer in a hyperglycemic environment, and then it subsequently goes on to develop hypoglycemia when it's born because it's still pushing out all of that insulin. The next question, would you ever use insulin and metformin together? Yes. And that's exactly what the Mighty trial is looking at as well. Would we benefit adding metformin to insulin? Often we will have someone on metformin because that's what they really want to be on, and then they need to go on to insulin. So we then have the option of stopping the metformin or continuing the metformin. It depends on the individual. If they're of a thinner frame, then I tend to stop the metformin. If they very clearly have insulin resistance with obesity, then I'll continue the metformin because that's going to reduce the amount of insulin required. And I'm hoping by the end of the Mighty trial, we'll be able to demonstrate the benefit of adding metformin onto insulin. The next question is can you please verify why insulin is first line and not metformin? Insulin's, well, it purely comes down to complete safety. Insulin doesn't cross the placenta. It doesn't impact the baby in any way. You don't have to take into account fetal size. And it's what all the guidelines still have in it as recommended as first line through a consensus statement across the world. It doesn't mean that you can't use metformin, but we've got still the greatest amount of evidence for insulin, which when you're having a first and second line is why we've got insulin as the first line. Next question is, would you still suggest metformin for pregnant women with a BMI less than 25? It really depends on what their pattern's looking like. If they've got mild elevated BGLs, and I think that metformin may be of benefit in getting their BGLs down, then yes, you could use metformin. You don't just have to be obese to benefit from the metformin in pregnancy, because they do have a degree of they do have a degree of insulin resistance. Okay, so when do you recommend first-line treatment of insulin to commence? When do you recommend first-line treatment of insulin to commence? Sorry, I'm not quite sure what you mean. I recommend the insulin be commenced when they can't, they're unable to get their BGLs within target with diet alone. That's when I recommend it. Sorry, are you asking how many weeks or what a blood glucose level is? Based on BGLs, anything that's out of target. So as soon as a patient has 2 blood glucose levels out of target within a week, that's when I look at commencing treatment. So I get them to be seen by the diabetes educator and the dietitian. I get them to see if they can abide by a gestational diabetic diet. And then what I look at is per 7 days, how many have they had out of range for fasting, post-breakfast, post-lunch, post-dinner. If they've got 2 or more in any of those columns, then I look at treating. So it's not a BGL, it's anything, even if it's just 1 or 2 points above. That's what I recommend. I just want to clarify that I'm not talking about having 1 out of target at post-breakfast and then 1 out of target post-dinner. I only look at breakfasts, I only look at lunch, and then I only look at dinner. Because often women as well, when they're needing the Nova Rapid, they may only need it for 1 meal of the day. Okay. So where are we up to now? In some birthing sites, being on insulin cancels them out for birthing at that site. Regional sites, in these instances, is using metformin an okay choice as first line. If you think you're going to be able to control it with metformin alone, then sure, give it a go. I can appreciate that some rural sites don't feel comfortable with insulin, but the doses that these women are on is often very low, but it's not something for me to debate with politics. If you think you'll be able to get them down with metformin, then go for it. All right, next question. Lantus has been used widely in hospitals, even it is not listed to use in pregnancy. Do you recommend Optislin now instead of Lantus? All right, so this is a lecture I gave to another group on biosimilar insulins. The long and the short story with the Optislin and Lantus is there is a new sticker on the insulin. So I have no idea why Sanofi has decided to rebrand Optislin. No one at the company has been able to give me an answer, and this is something I've been working on wearing my clinical pharmacology hat, but they've decided to rebrand it. So as of the 1st of July, you can no longer buy Lantus, you can now buy Optislin, and it's exactly the same thing. It's not a biosimilar, it's a bioidentical. It's the same stuff with a new sticker on it. So No, you're right. Glargine hasn't been listed for use in pregnancy, but we use a lot of things that aren't listed in pregnancy. And as I'd mentioned earlier, there had been debate for years about not using glargine, but now we're fairly comfortable with it. As a side note, with the biosimilars, there's another brand, Boehringer Ingram, I think is how you pronounce their company, is making Semglee. Now, Semglee is a biosimilar, meaning it's very similar to the original Lantus. It's not exactly the same, it's very similar. And should you your GP prescribe that one, then it should be okay to do a one-to-one swap, but you're not guaranteed because they're not exactly the same. All right, if trending is what, okay, sorry, that was last link to the further question. So how would you describe mildly elevated BGLs warranting second-line metformin treated rather than insulin commencement straight away? How would you describe mildly elevated? All right, so mildly elevated, meaning that it's less than 1 out of target. So if you're talking about a fasting, when we've got your target of being less than 5.1, any fasting greater than 6, you probably won't be able to get under control with metformin. Any postprandial that's already been dealt with by diet, that is greater than say 7.5, 7.7, you probably won't be able to get under control with metformin alone, and then I would be thinking that they'd be needing insulin. All right, so let's get back to the presentation, but feel free to keep putting up questions and I'll see if I can answer them for you. All right. Let me just have a sip of this cold cup of tea. Oh, okay, sorry, thank you for that. Now, I just thought I'd touch on intrapartum management of gestational diabetes. So when they're not diet controlled alone, what do we do with the medication that they're on? So what I recommend is that women with gestational diabetes stop their metformin and their insulin when they're admitted to hospital for either their induction of labour or when they present in labour. So if they're coming in for a section, I tell them that they can have it all the night before, but then nothing on the morning that they present for their section. If they're coming in the night before for gels for an induction, then I tell them that, because they normally come in after dinner, just don't take anything from the moment you walk in the door. And if, of course, they're already in labour, then don't take anything. If they're going to be in hospital for a couple of days, if they're getting steroids, then they'll probably actually need insulin to get their blood glucose levels under control while they're getting that betamethasone for the fetal lung maturation. It's rare that they will need correctional insulin during their labour stay, but it does happen. Most women with GDM, it's not severe enough that we need to give them any. And we aim for a target of 4 to 7 while they're in their labour period. Postpartum, I recommend that you just stop monitoring 24 to 48 hours postpartum if their BGLs are within the normal non-pregnancy range. So after women have been on the labour ward and then they go back to the maternity ward, I get their blood sugars to be monitored for the next 24 to 48 hours. And as long as I wouldn't want to be treating them as though they had type 2 diabetes, they can stop monitoring and just have a repeat oral glucose tolerance test in 6 weeks' time. It's quite rare that anyone with GDM needs to stay on any medication postpartum, but women with type 2 diabetes can generally go back to what they were on pre-pregnancy. But as pregnancy is a stressor on the body, they may need higher doses postpartum as well. So I just wanted to touch on the importance of weight as well. So I stole this graph from my old hospital, the Martyr Mothers in Brisbane, but I really like it. And you can get it off their website. I give this to women when I see them early in pregnancy, particularly if they're larger size, to enable them to track their weight throughout pregnancy. So women who are greater than 30, have a BMI greater of 30, then they should stay in this blue group down the bottom. Their weight shouldn't really go up by any more than 5 to 9 kilos throughout their pregnancy. Whereas if you've got someone who's underweight, then they should be gaining more through their pregnancy. This is linked with GDM often, because often women with GDM are overweight, but I just think this is a useful thing for women to have in general. All right, so I just wanted to touch on the complications of gestational diabetes, and many of you would already be keeping an eye out for these in your women, but if not, maternal complications, we definitely have strong evidence that we're needing to try and ameliorate the risk of preeclampsia in women with type 1 and type 2 diabetes by giving them aspirin. We don't give women with GDM aspirin because aspirin really needs to be given, started to be given from about 10 weeks gestation. And if we're not diagnosing women until 24, 28 weeks, then the placenta's already formed, and the benefits of giving them aspirin to prevent the preeclampsia, it's not going to be there. But we do need to keep an eye out to see, keep an eye on their blood pressure. And if they are becoming hypertensive, then to do a urine protein creatinine ratio, their electrolytes, liver function tests, platelets, to see if they're developing it. Women with GDM also have a high risk of polyhydramnios, needing an induced labour due to the increased fetal size, ending up needing an operative birth like a C-section. The postpartum hemorrhage is linked to how big the baby's been inside and infections. Long-term risks then, whilst it doesn't happen all the time, it's very, very common for a woman to have GDM in a subsequent pregnancy and to have it diagnosed earlier with each pregnancy. I look at GDM as a stress test for the body, like getting someone to go and do a stress test for their heart. If they get GDM, then they will progress. There's a high risk of them progressing to type 2 diabetes. So 5% go on to type 2 diabetes within 6 months of the baby being born, and 60% will go on to developing type 2 diabetes within 10 years. They've also got a higher risk of cardiovascular disease, so they should be getting follow-ups with their GPs for cholesterol, blood pressure, etc. Fetal complications, so there is a higher risk of congenital abnormalities like with type 2 diabetes, but not to the same extent because it tends to be purely a third trimester, and all the organ development occurs in the first trimester and first half of the second trimester. Babies, of course, can have hypoglycemia if their mother is hyperglycemic, so they're running at a hyperinsulin state while in utero. And then the macrosomia leading to shoulder dystocia, bone fractures, nerve palsies, etc. These babies are also at risk of having impaired glucose tolerance themselves and developing type 2 diabetes and becoming obese. So I just wanted to ask if there was any further questions. Otherwise, I've got a few examples of different women I've seen over the last few weeks that we could go through. So I haven't seen any pop up, but feel free. Yep. Beautiful. All right. So given that this isn't a live mic situation today, I won't be able to get you to call out what you feel to be the answers, but I'll get you to do it yourself and see what you think. So I had a 36-year-old woman who was G2P1 at 17 weeks gestation. She had gestational diabetes last pregnancy, and so that was a high risk factor that triggered her to have an early oral glucose tolerance test at 16 weeks. She came back with a fasting of 5.4. She had a 1 hour of 8.9 and a 2 hour of 7. So does this woman have gestational diabetes? Does she have type 2 diabetes? Is she fine and has neither? How would you go about treating this woman? So I'll give you about a minute or so just to think, what would you do if this woman had presented to you? All right, so this woman, all right, sorry, I was just looking at the Zoom chat. Thanks, Helen, for replying. Yeah, so that's one way that you can write in as well as to what you're thinking your answers are. So I think what Helen's done is fantastic. I diagnosed her as having gestational diabetes and rather than type 2 diabetes. So my apologies, where there's a 5 for the diagnosis of type 2, that's supposed to be a 7, just correcting that there. So diagnosis of GDM, she is above her fasting, which is 5, she's 5.4. Her 1 hour is less than the GDM, and her 2 hour is less than the GDM as well, but it's also less than the type 2. So for the diagnosis of GDM, you only need one of the fasting 1 hour or 2 hour to be elevated. So what I did was got her to start monitoring, and I thanked my diabetes educator colleagues for teaching her how to monitor her blood glucose and getting her all set up, and also for referring her onto the NDSSs so that she could get supplemental strips while she was pregnant at the reduced cost. So dietary education was really important for this woman because this is what I'm describing as mild elevation. So it's just above our treatment target. And so diet may be able to get this under control. I find that diet is very difficult to get fastings under control. Women who have got elevated postprandials are able to make modifications to get it under control, but it can be very, very difficult with the fasting. I often find that women having half a glass of milk prior to bed or some cheese does help bring the fasting down, and diet may be able to get this woman down to target. So if we're talking about that metformin insulin situation, here I would talk to her about both options. So yes, insulin is first line, but here she is in that what I consider mildly elevated state. And so metformin may be sufficient to keep her fastings under control. We need to remember that this woman is at 16 weeks, she's now 17 weeks. These were done at 16 weeks. She's got a lot of her pregnancy to go through, and she's going to become more and more insulin resistant as the pregnancy progresses. So starting her insulin now would definitely not be the wrong thing, because she will need insulin throughout her pregnancy, because I'm almost certain she won't be able to keep her sugars under control simply with metformin. So I had some questions. Do Diabetes SA and NDSS provide machines for these type 2 mums that require testing blood glucose so regularly? The new machines, the scanning type ones. Oh, are you talking about a Libre? No, we don't, not that I'm aware of. I don't believe there's any funding for the Libres, and you can get a Libre through NDSS if you've got type 1 diabetes, but they're the only cohorts. So if you're type 2s or you're GDM, then you don't qualify for any of the continuous glucose monitoring or the Libre, which is technically not continuous glucose monitoring, but kind of falls into the same group. So next question is example 1, as elevated fasting, would insulin be a better first line? Either or. This was an example of where you could potentially use the metformin, but she will end up needing insulin. I hope that helps clarify. If not, please ask. Okay. Next question, next example. So a 25-year-old G2P1 came in at 32 weeks gestation. She has a history of GDM, but nil other significant, and there was no fetal issues of significance either. So this is what her BGLs were like when she presented to me. She had only been on diet controlled previously. And so what would you do with her? Give you a minute to think. All right, so let's have a look. Oops, here. All right, so I've highlighted all the elevated levels in red. So she has elevated fasting, and she's more than just 2 out of the last week. It's every day. Looking at her post-breakfast, things are pretty good. Her after lunch were also elevated. And her after dinner is also mostly elevated. Now, you'll see that there's some that she's missed, and I do always tell my women that if you miss it, just put a dash, be honest. There's been numerous times that I've had women make up numbers, and it's been really confusing to work out what they're doing. So from the beginning, I just give them the heads up, look, I get you're pregnant, I get life's crazy. If you miss it, just mark that you didn't do it, and I won't be angry or anything, because sometimes they worry that the endocrinologist will yell at them, and that's the last thing I do. I just want total honesty. So here I started her on Protophane, and I started her on 8 units. If you felt uncomfortable starting on 8, you could have started a little bit lower. In all honesty, I would have been very happy to put her on 10, and I just started her on 8 because that gave her a little bit of confidence that we weren't starting too high. This was a very nervous woman. I didn't give her anything for her breakfast, but I started her on 4 units for her lunch and her dinner. And we've got a great diabetes educator service where they can call up from home rather than coming in for face-to-face appointments all the time. And I ask them to be reviewed in 3 days. And the diabetes educators I work with have permission to up-titrate the insulin. So that's what I did with her. Another question's come through. So nothing noted about maternal mental health yet. The stress levels women newly diagnosed with GDM experience are often extremely high and cause significant anxiety and perinatal psychological trauma. If GDM is a stress test for the body, women diagnosed should all be able to access specialist perinatal mental health support to reduce their stress levels, anxiety, depression, and associated complications to prevent unnecessary psychological harm, shouldn't they? Yes, it would be great if women do express any anxiety, stress, or concern. I do try and refer them on to mental health support. I acknowledge that the mental health support that we've got isn't good enough, and unfortunately, there's not always enough available. I take your point. Yes, it's very important that we do try and give women the best mental health support during their pregnancy. Thank you. Okay, so let's go on to the next example. A G1P0 woman at 30 weeks gestation. So she's got no significant past medical history or pregnancy history, and there's nothing with the baby. So what would you do with this woman? What would you get her to keep her diet? Would you refer her to diabetes educators? What would you start her on any medication? I'll give you just a moment. All right, great. What are we thinking about this woman? So this woman, I recommended that she go on to insulin, but she declined. My reasons for recommending that she go into insulin, particularly prandial insulin with her dinner, is the elevated levels. So I haven't told the whole story with this woman. This was the third time I'd seen her and the third time I tried to start her on any medication. And she was insisting on doing it with diet alone. That's why we'd got to 30 weeks with the sugars still not yet controlled. We provided lots of education and understanding to what her particular concerns were. And the concerns simply came down to she just didn't want to take the medication, which I completely respect. She wasn't concerned that it was going to harm the baby in any way. But in the end, she was happy to start some metformin, which we up titrated by 500 milligrams every 3 days. Now, I don't jump women straight to the 2 grams because they get the nausea, diarrhea, other abdominal, gastrointestinal issues. I did advise her that she would likely need to go onto insulin, and I gave her a week to see how the blood glucose levels were and whether or not they were in target before progressing to insulin. So here it was great that this woman had decided that she would go onto some treatment, because once she understood the potential harms to the baby, she was more amenable to starting treatment as well. And this is a really good example of actually providing that education and understanding what the patient understands and why they're not doing things. It's rare that you'll find someone who's non-compliant just simply because they refuse to do something. There tends to always be a reason behind it, and lack of education and understanding is often one of them, which is why it's so fantastic that we've got diabetes educators who do have more time to spend with the patients. So let me look at the questions. All right. Could you please explain how to decide the starting dose from insulin based on 0.3 units per kilo? All right. Next one is also, what guides your decision making around how many units for insulin to commence? All right, so let's jump up. Unfortunately, the world of endocrine really comes down to experience. And this is one of the hardest things when trying to write guidelines, particularly for clinicians to give to diabetes educators as rules per se as to what to do, because endocrinology and diabetes is gut work. Point 3 is probably not a bad place to start, but I would be guided by what your GP has advised you to start on, because given that it's a medication, I'm assuming that you're not picking the doses yourself unless you're a nurse practitioner who has the ability to prescribe medications. They don't need as much as 0.4. I would even think around the 0.1 to 0.2, with 0.3 units per kilo being the upper. And as I had in my initial, starting around the 6 units for Protophane if it's above 5.5, say. The Nova Rapid starting about 2 to 4 units if it's up around the 7 mark. I did look to see if anyone's been able to come up with a guideline, but it really is just experience, and I'm sorry, that's not a useful thing for me to say. But the more patients you see, and even just touching base, if your local health practitioner is not certain, call your local city hospital. They've got endocrine registrars on call 24/7, and really don't mind taking a phone call. I've got a patient and these are their blood sugars. What should I start them on? If you're a rural GP, very happy to provide that advice, because yeah, as I said, unfortunately, it's just gut and experience. Okay, example 3. Dietitian review of dinner and encourage movement after dinner. Yes, that's definitely a good point as well. I find a 30-minute walk after dinner is really good to help with the dinner postprandials. Now, when I worked in Brisbane and when I worked in Darwin, it was much easier to get people to go out and go for a walk after dinner. But in Adelaide, in the middle of winter, it's freezing cold and it's dark, and you've almost got Buckley's chance of getting anyone out the door. So if they're able to, I think that's really great, particularly women who are pregnant during summer. So yeah, thank you to the person who recommended that. Now the next, why are the 2-hour BGLs level less than 8.4 are in red? Because we're aiming a target of 2 hours post blood glucose to be less than 6.7, where that's our treatment target. So let me just go back here. So yeah, anything less than 6.7. So here I'm okay with that 6.7. I'm okay with the 6.2. My apologies, I missed a 6.9. That was an error. That one's too high as well. So yeah. All right, I think this is our last example for the evening. This is a woman I had last week. She's G3P2, 28 weeks gestation. She was, I think, she was Filipino, with a very small frame, and picking someone, you wouldn't think that she had diabetes based on her weight, if you're using obesity as your main factor for predicting who has diabetes, which is not always correct. And she had a really small baby, and we were actually keeping an eye on her baby because it was small. So what form of treatment would we use for this woman? And I want you to think about how the dilemmas with this one, with how tight do we go for glycemic control? What medications would we or wouldn't we use? This one's a little bit more difficult with that IUGR baby. And for people who aren't familiar with the acronym, IUGR is intrauterine growth restricted. All right, so this woman had mainly elevated fasting blood glucose levels. Now, when we were talking earlier, could this be potentially metformin rather than insulin because of the numbers? Yes, these numbers would be potentially manageable with metformin, just to give you a guide of that mildly elevated, so to speak. But this is a small baby, and as the studies that I've referenced earlier had demonstrated, metformin does cross the placenta and it does result in decreased fetal weights. So it's really important that this woman is not started on metformin. I do make sure that I've seen the most recent scan of the fetus prior to picking any medication, because I don't want to be prescribing metformin to a small baby. I started this woman on 4 units of Protophane and reviewed in 3 days to determine whether or not we needed titration. If you were concerned because she's just over target, you could have started at 2 and then titrated it to 4. I knew I was going to get to 4 just through to experience, so I just started her there. Now, as I'd mentioned, we do have this dilemma about how tight do we go in women with small babies. So in this case, we're not focusing on getting the blood glucose within target to reduce the baby's size, but we still need to think about fetal hypoglycemia following delivery. Now, unfortunately, we don't have any very good studies in this particular cohort, but it is still felt that we're wanting to aim for good glycemic control in mothers of small babies, mainly for that neonatal hypoglycemia and avoiding NICU stays. But we don't need to be too aggressive, just try and keep them within target, but not going for getting the 4s rather than close to 5. All right. So these are a couple of resources that I use all the time. The NDSS, Gestational Diabetes, Caring for Yourself and Your Baby, which I'm sure many of you are already handing out or advising women where to download it from. Once again, having come out of Queensland, I've been exposed to their pamphlets, and this is one you can download yourself off of the internet. Healthy Eating for Gestational Diabetes Mellitus. It's a really simple version, and it comes in multiple different languages for your non-English speaking population. And the one on the far right is the one I referenced about the women's and children's. That's really useful to give to women, and even look at yourself, just to refresh what is a good way to educate about gestational diabetes and diets. So I've managed to come in half an hour under time. So if you've got any questions, feel free to fire them at me, or you get an extra half an hour of your evening to just go and relax. Barbara, if you were wanting to say something, your mic's on. Oh, off, sorry. So, yep, you're coming through, great.
Thank you, Dr. Gillard. So if there are no further questions, that concludes tonight's education session. I'd like to thank Dr. Gillard for a very informative education session, and we hope everybody found it very valuable and relevant to your practice. A reminder that you'll be prompted to complete a brief evaluation when you leave this webinar. Please take the time to do this as this response will help us for further education. Please have a number of education sessions coming up. Sorry, Safnia does have a number of education sessions coming up. So if you jump onto our website, you can have a look at the upcoming education sessions. Thank you for your attendance, everybody, and thanks again, Dr. Gillard. We really appreciate it.
Thank you, everyone, for joining, and thank you for your questions.